Good morning, everyone. Can't hear this. Hello.
Oh, now it is. Oh, yeah, you can definitely hear me now.
Okay. Good morning, everyone. Please come forward. I know it's we're quite a few number of people in the room, but I think more closer you come, I think we can have this session as a very interactive session. We're going to be talking about residual lesions after congenital heart disease surgery. It's something that we encounter in day-to-day practice in cardiac intensive care. And I'm chairing this session with Kaylin Rood. Kaylin, do you want to introduce yourself?
Yes, Caitlin Rood from Boston, Massachusetts at Boston Children's Hospital. Happy to be here.
Yeah. So we'll start off with the first speaker. Julie Walker is a cardiologist in Geneva Children's Hospital and is going to talk to us about investigations, looking for when you have a situation with residual lesions and which investigation gives us the best yield. So Julie, the floor is yours. Thank you.
Thank you very much. Thank you to the chair. Thank you to the organizer of the meeting for giving me the opportunity to present this talk. I have to say that when I got the title of my presentation, I was a bit puzzled. In it for an answer, CHO. So I actually questioned myself, Googled, thought maybe it's an investigation that I haven't heard about in those years of pediatric cardiology. And then after a lot of research and asking Dr. Polito, it appeared that it was echo. So it's not corrected in your program, but it's actually echo, and don't expect a new way of diagnosis residual lesions. So the problem with residual lesion is when you work in a center, when you have a very good surgeon, it's pretty rare to get those very extreme residual lesions that are published. So I understand that those are the extreme cases and everybody can make mistakes, but it's very uncommon to find that kind of lesions on the left side of the screen. You have a complete occlusion of the left PA and of the SVC after a gland procedure, or on the middle of the screen, very severe stenosis of a RV2PA conduit, and on the right side of the screen, a complete occlusion of the right PA. So there is no data and study to show that, but we all know that, of course, the better the surgeon, the less residual lesion you have. And there's not a lot of literature on residual lesions, so it was very a challenge to get that presentation with the evidence-based data. When I thought about residual lesion, I first thought about how to classify them and what do we need to look into. And I guess residual lesions, you can first distinguish between the expected one and the unexpected one. What I mean is that expected one, you can have a very apical VSD that you know of before surgery, and you've decided during your planning not to go and close it, so you will have this residual lesion, it's expected. You can have significant and insignificant residual lesions, so after a tetralogy, a fallow repair, you will never have a perfect pulmonary valve. Either you leave a little stenosis if you want to leave the native annulus in place, or you will have leak if you do a transannular patch, or if you put a contact right. It's not going to be perfect, but it's not necessarily significant to go back, right? And we'll talk about that later. And then I thought about timing of presentation of residual lesion, when to look for them, when to act on them, and then the best modality to diagnose them with echo, CT, MRI, and cath. Why do we? Why are residual lesion diagnosis why is it important? So there is a study of the residual lesion score. That's a large prospective multi-center study that's designed to investigate the association of residual lesion with early and mid-term outcome following 5 common congenital cardiac operations in young children. And you can see that actually having, on the left of the screen, you have the 5 congenital heart disease that they've studied. You have Fallow, you have a CVSD, you have Arch and VSD in Norwood, and you can see that the residual lesion score of 1 is no or trivial residual, 2 it's minor lesion, and 3 is major or reintervention before discharge. And it's no surprise that complete AVSD and Norwood are the cardiopathy that are more prone to residual lesion. And there is an association between residual lesion and major medical events and length of stay in the hospital, so it's important to look for them. Of course, you can feel that if the child is complex, has a complex CHD, if the surgery is complex, which is often linked but not always, in youngest children you will have an increased risk of residual lesions. Whereas if you have a good surgeon, and I think one of the thing I want to insist on, good preoperative assessment and planning, you will probably decrease the risk of residual lesion. And by good preoperative assessment and planning, I think about, of course, a thorough echo, and then other imaging modalities if you feel that the echo is not enough, and including a pre-op TOE, the transesophageal echo. And you have to discuss the patient in a cardiosurgical meeting and really discuss about all the issues and all the surgical planning. If you do a pre-op TOE, maybe ask the surgeon just to leave you a bit of time to do the echo, because you can see the diathermy here. So sometimes you go to the OR, you want to do your pre-op TOE, and the surgeon is already starting, so you can't see anything. So when we look about the timing of the residual lesion presentation, actually the window of opportunity to diagnose them and to address them, the first time is really just right after cardiopulmonary bypass win and before protamine is given. The TOE is very, very important in that situation, because we'll see that the prognostic is much better when you address the residual lesion at that time than later on. So that's the time to shine, the time to look for residual lesion, discuss with the surgeon, and make a decision about it. And then, of course, you will look and address residual lesion if you have a child in the ICU that's not doing the way it was expected to be doing. And of course, a lot of our congenital heart disease patients will have residual lesion that will need to be addressed much later in time. It's not going to be addressed today. So this is a study that's 10 years old, but that actually looked into the timing of the residual lesion management. And you can see that IO is the intraoperative, so just right after TOE, and PO is postoperative. And you can see that the length of stay, the adverse event, the hospital cost, and the mortality was increased if the residual lesion was addressed postoperatively compared to intraoperatively, whereas the difference between no residual lesion or intraoperatively lesion was not significant in between for those outcomes. So very important to do the pre-op TOE. I would say it's mandatory. I wouldn't understand why we shouldn't do an echo after a surgical repair. I think in children, it should be performed by pediatric cardiologists that know the patient and that know how to interpret the pictures and put them into the context. I know in adults it's often done by anesthesiologists, but I think with congenital heart disease, it's very important to have the pediatric cardiologist doing it. There are different probes and different sizes, and we'll just come to that a bit later. And of course, there are some structures that are not easily seen with the TOE, especially the anterior structure, so the PAs, and especially the left PAs, or, for example, the Glenn anastomosis. So there are really few contraindications to transesophageal echo in a child that was already intubated, so you don't have to do an anesthesia for that. But of course, if you have severe respiratory depression, the tube is not, the anesthesiologist is not happy with his ET tube, or you have an esophageal stricture or something that's very rare in children, then you shouldn't put a probe in. There are some congenital heart disease, like TAPVD or Fontan, that sometimes don't really tolerate the probe poking from the posterior side of the structure, but usually you try. Most of the time it works, and if the child is not tolerating it, then you can stop. The manufacturers have put weight limit for the probes that we have between 2.5 and 3 kilos for the micro multiplane probes. In practice, we often go a bit lower than that. And when the child is a bit bigger, if you can use bigger probes, like for the adult probe, it's usually 25, 30 kilos. But if we think that a probe fits in a smaller child, we have to weigh the risk-benefit, but a bigger probe gives you better image quality because you have more crystals and you have an improved contact with the esophagus. But of course, you can also do a bit of harm in terms of bleeding of the gastrointestinal mucosa. If you can't do a TOE, you can do an epicardial echo. So either you wash and you do it with your left hand, and you manage your machine with the right hand, which is, for us, easiest because you know what you're looking at. And if you're not that lucky, then the surgeon decides to do the echo, and then you have to show him what he's showing you, and it's not always very easy, believe me. But that's another alternative, to look at the structures that are not easily accessible by a TOE, or when the TOE is contraindicated. So with the TOE, you evaluate the adequacy of the surgical repair, you assess the ventricular function, and just remember that the findings you find on TOE are influenced by the anesthetic depth, the hemodynamic states, and the drug that the patient is on. And you will see if there is some obstruction, some leaks, or stenosis of the valve, some residual shunt. And the decision to go back on bypass or not is not only determined by your finding on the TOE. You have to summarize all the information, clinical information, the hemodynamics of the patient, and the risk versus the benefit of the intervention. And really, we tend to also do some invasive measurements with the surgeon that pokes the needle in a few chambers, just to make sure that we get it right and that it's significant. That, for example, you have a flow acceleration across a valve. You have a gradient on echo that's 40 millimeters of mercury. The surgeon can measure the pressure into the right ventricle, into the PA, and see if the invasive gradient is as much as what you see on TOE. And if you have a residual shunt, for example, you can do a QPQS with the anesthesiologist and with the surgeon, and you can decide if that needs to be addressed or not. So it's not only TOE finding, but really incorporate that into the clinical situation. And I think the surgeon's gut feeling is really important. The surgeon knows. He knows before you go into the room, and when you enter the room, you already feel he's happy or not. And when he has a doubt, and on top of that, you show him that something is wrong, then, of course, it encourages you to go there. Of course, as I said, you discuss with the anesthetic team, and it's a common discussion, and then the choice to go back or not. And then, so that's for the TOE. Once you decide the TOE is acceptable, the patient goes to the ICU. Then when do you assess for residual lesion? So if the patient is clinically well, then he probably will have another routine echo, 1, maybe 2, and then he's discharged home. You're not going to bother with that. So if he's not doing clinically well, you do 1 echo, 2, 3, 4, 5, 6, 7, 8. You do all those echoes, and then maybe you find residual lesions, and then you go to surgery, or you need to do other exams to decide to go to surgery. Or you don't find any hints of a residual lesion on echo. Is the patient going better? Yes, then forget about it. He's still not doing better. You still do echoes, and maybe you do other exams, and that will lead to maybe the diagnosis of residual lesions. So really, it's those patients that are not doing well postoperatively unexpectedly. What I mean by that is that if you do an arterial switch to a 1-year-old patient, you expect him to need a bit of ECMO support after you switch. But for a patient that presented with very stable, that went on an uncomplicated bypass course and is not weaned off bypass, then you really need to think about residual lesions. This study in 2014 showed that in patients on ECMO, they found 25% of residual lesions, and the most of them were diagnosed by cath procedure, and 20% of them by echo. And the earlier detection of the residual lesion was associated with the better prognostic and ECMO decannulation. When you want to do other imaging, you can think about CT angio or MRI. So CT, the downside of that is that you need to transport the patient. And when a patient is on ECMO, it requires huge support and a lot of people and a lot of programmation. And that's really something that's also critical for the patient and dangerous for him to be moved. So you really have to think about the indication for that. Of course, the CT angio were some radiation, but it's rapid acquisition, and you can see a lot of residual lesions. On MRI, there is, some of the residual lesion can be diagnosed by MRI, but if the transport is difficult, the length of the exam on MRI is also problematic. It's ECMO incompatible, pacemaker incompatible, well, with epicardial lead at least, and availability of this modality in an emergency setting is not always there, but it also can give you some good information about residual lesions. And I just put a case of a coronary artery stenosis after a switch procedure, but I think we're going to talk more about that a bit later. What about cath? So indication for cath: unable to wean from ECMO, unable to close the chest, unable to extubate the child, and or morphological problems that have been revealed by imaging, whereas it can be a transthoracic echo, transesophageal echo, or angio. And you really have to weigh the risks and benefits. So, of course, it's going to be it's going to be diagnostic, and you can probably intervene if there is something that's amenable to a stent or an intervention. But you have to take into account the risks of the cath, and the transport of the patient is still there. But then when you balloon or you put a stent, or you can disrupt the fresh suture. You can, if the patient is on ECMO, he's coagulopathic, he can bleed. And sometimes, I just put it that to have a think about it, the futility, because sometimes a patient is really sick, is not doing well. We've been 3 times to the OR, and we do the cath to make us feel a bit better, but sometimes the patient is already in multi-organ failure, and it's not worth, and it's probably not the best thing to go into the cath lab. So we just also have to consider the whole clinical picture, and sometimes, know how to stop with our intervention. But despite those risks, a lot of studies, and I've just took one example, have shown that actually cardiac catheterization, including intervention, can be performed safely post-operatively, and they have a good results with a few of those side effects of bleeding. So I've chosen a few cases to illustrate my talk, and then I think we're going to have a roundtable to go more into depth on one or 2 cases. So I just wanted to show you how when theory helps mid-surgery. We had a patient with congenitally corrected transposition of the great artery VSD PS and a mild to moderate MR on epicardial echo. The surgeon and the parents really were keen to do a double switch procedure, including a double rotation of the aortic and the pulmonary route. But we thought that the physiological surgery would be repair would be much better. But the surgeon did a mitral valve plasty, and then wind of the cardiopulmonary bypass, we did a TOE, and that mitral valve that's on the right side is still leaking, and whereas the tricuspid valve that's on the left side was perfect. So we decided to leave this left ventricle subpulmonary, leave the right ventricle subpulmonary, and address the VSD and the PS, and do a physiological repair. So that's one of the use of TOE. It's not very frequent to do that, to do a TOE in the middle of the surgery, but that can sometimes help to decide the procedure. Sometimes TOE is too severe. It's too worrisome. We have a child with transposition of the great artery, VSD, and coart, and he has residual pulmonary stenosis. And you can see here on, the image quality is not great. You can see the two vessels going side by side, and you have on the far right of the screen the pulmonary, the neo-pulmonary artery, and you have a gradient on echo that's probably a bit overestimated with the dot here, but at least 30 millimeters of mercury. And then we did the invasive gradient. It was 17, and we decided not to go back, and the child is doing fine. We really have to be a bit careful about the gradient that we measure on echo. This is a child with a mitral valve repair, and we had a stenosis, a mild leak, but a stenosis, and we were wondering, the mean gradient at the beginning when he was wind of bypass was 5, and then we just waited a little bit, tried to, decrease a bit the aminergic support, and then we could find that progressively this gradient is going down. So I have the feeling that basically we tend to overestimate the stenosis and underestimate the leaks on TOE, but I would be interested to know what you think about that. And then when TOE prompts immediate reoperation, so that's a case from last weekend. We had an obstructed supracardiac TA PVR, and the child came off a bypass, and we were really not happy with that picture. You can see that the left pulmonary veins are coming into the collector, and you can see the aliasing with the flow acceleration across the connection between the collector and the left atrium. Really, it took a lot of convincing to the surgeon to go back. He did some invasive pressure measurements, and the gradient was too high. It was 4 millimeters of mercury of difference, so he decided to go back, and this is after his second repair, and you can see that the connection is much wider. This time is the right pulmonary veins, but that doesn't matter. The connection between the collector and the left atrium is much nicer. And then, what about a case of cath for residual lesion? So we had actually, that's a French acronym. So it's a PAVSD type 3. So pulmonary atresia with open septum and many collaterals. We did a pre-op occlusion of the collaterals immediately pre-operatively, but then the surgeon says, there's something wrong. During the surgery, I had a huge amount of flow coming back into the left atrium. So I think there's some collateral that you missed, and you need to go and close them after surgery. So So we went, and I don't know why the quality of the picture is not great, but you can see here, I have a pointer, maybe I'll go there.
Yeah, I think that might be, sorry.
Hop. Oh, no, sorry. Can you see? Yeah. Yeah, I don't know what I'm pointing at, though. Yeah, perfect. So I'll do that because it's much better. So you can see we have a pigtail in the descending aorta here. You can see that we have a plug that we've put previously into one of the collaterals that was going to the right lung. And we can see here that there's a collateral that's pretty huge, that's divided into at least 2 branches. We had identified that collateral before, and we had put 2 plugs at the origin of the collaterals. You can see that one of our plugs had migrated much deeper into the pulmonary artery, and then where was the other one? So we looked for it, and it was all the way down into the left femoral artery. So we first addressed that collateral, so we put a big plug at the origin of that collateral, and you can see on the angio that's a nice result with no residual flow. And then we had to go and retrieve that little plug, we did that with a bioptome and just, draw it back. That's not by the book, but that's what works at the time. And then we did this is my last case. It's a multimodal imaging for a complex case. So it's a 3-year-old male with transposition of the great artery. He had an arterial switch repair at our center with 5 days of ECMO, and he had continuous poor cardiac function and enlarged left ventricle. And very not very good left ventricle, not contracting well. And we knew that there was some sort of neo-aortic regurg, but not really severe. So we didn't know that there was something that had to be fixed. We just thought that this left ventricle is bad, he's not adapted. And so we went to the cath lab to make sure the coronaries were fine, and actually they were perfect, there was no complication. But on invasive hemodynamics, the LVEDP was 40 millimeters of mercury, and so really not great. No wonder we couldn't rid of inotropic support and ventilation. And we went to the MRI, and actually, of course, the ejection fraction of the left ventricle was low, but really what was a bit unexpected was this regurgitant fraction of 35% of the aorta, which was completely underestimated by our echo. So he went back to the OR, had his valve fixed, and was then able to be weaned from inotropic support. I'm not going to tell you that his left ventricle is perfect now, but at least he's doing well with no inotropic support. So I'll come back to my place. Thank you so much. So in summary, this was just a little overview of the residual lesions examples and how to address them. I think a good planning of the case can lower post-op residual lesions, and I really encourage you also as cardiac intensivists to attend those meetings, discuss the cases, and know what to expect after. You have to look for residual lesions when the child is unstable unexpectedly. I would really advocate for not leaving the OR if you are in doubt of a significant residual lesion, or at least without a plan to address it. I would start with the echo and then adapt to the situation and add some other imaging modalities and integrate all the results, but don't forget the clinical state of your patient, hemodynamic monitoring, echo, angio, MRI, and cath. And the decision to intervene really has to be taken in a multidisciplinary team. It's never a decision of one person only. And just to conclude, there's a citation that says, "We all strive for perfect surgical intervention, but not infrequently we face residual issues. For the time being, it's our judgment and experience that help us to walk the line between solving these issues and making matters worse." And Dr. Pizarro say, "I look forward to the day when good evidence will facilitate this decision." Thank you very much.
Thank you so much, Julie. That was a very comprehensive discussion. I did have one question, and then I certainly think we should open it up. I think this is a topic that really lends itself to a multidisciplinary discussion. You talked a little bit about preoperative assessment modalities, and I certainly think that's a bit of a controversial topic at my institution, especially in the neonatal population. And I wondered, at your institution and then for other folks as well, what lesions are we most likely looking for CTs on, especially in the neonatal population, and what are you using preoperative MRI and CT for? What populations are you using that for?
Yeah, I think it's all very difficult in young children to know what's the best imaging modality, and also the modalities are evolving. And like, for example, for a long time we would use CT for coronaries, and now with new protocols, they can look at coronaries much better with the MRI. So I think it's really a discussion with the radiologist. Our neonates, when they have congenital heart disease, are actually in the ICU. So it's always the same team, being neonates or older patients, and it's really a discussion with the radiologist, intensivist, and us. So yeah, it really depends on the situation.
You didn't say surgeons, because in our institution, it's all the surgeon is the one deciding if the CT will be done or not.
Yeah, I forgot about the surgeon. How can we forget about the surgeon for once? We forget about him. No, of course, and of course, at the end, he's the one that's going to operate, so he is the one, that wants to. But sometimes, I don't know how it is in your institution, but, sometimes they're like, yeah, I'll go anyway, because, if the diagnostic procedure would delay the surgery, then it's a problem, because it's already booked, and, he wants to operate, and sometimes it really takes a lot of convincing to the surgeon. Of course, he's part of the team, but I think it's a really a common decision, and sometimes we have managed to convince him to go further into exploring.
I was going to say, I think one that pops up for us at Boston Children's is the coronary anatomy in DTGA, because I think that we certainly have surgeons who are along the lines of, even if it's not completely clear by echo, I have to do the switch, so I'm going to see what it is when we go. And then other surgeons who really want that delineated, and we have to try and get a 2-day-old down to CT scan and think about beta blockade and things like that and breath holds. So I do think it really depends on the surgeon as well.
Yeah.
But that discussion always comes up, I think.
Yeah, I think there was, I can't remember now which study it was, but it was a discussion when I was working in Australia and Melbourne. The surgeon there told me that actually what predicts the complication for coronary artery is not that the child has an abnormality, but that the surgeon knows it before. So he said, if he has an anomaly and we don't know before, we can address that. But if we know, we're a bit stressed, and maybe, so it all depends. Of course, coronary is a big thing. I guess for us, the coronary artery anatomy is very important when the surgeon is thinking about double root translocation. That's one thing. I think the switch is less complicated. And when he has to put a conduit, or if you have an IVA, an LAD crossing the right afro tract, and you don't see them properly on echo, those would be the two indications for looking more into coronary artery anatomy.
Thank you very much, Julie. We're going to try get the next two, this session on the round table. We will have Jürgen Herrera joining through Zoom, and Maurice Baghetti joining also through Zoom. So we actually were looking forward to having them in person in the room, so we could have addressed these issues about, when you have different views and opinions when it comes to what a surgeon would like to do, what an intensivist, and what a cardiologist would like. And I think, unfortunately, for whatever reasons, they're not able to be in the room, but they're going to join us virtually. So let's hope they're there. Good. Cool. Super. So Jürgen and Maurice, can you hear us?
Yes, very well.
Okay,
I hear you.
perfect. Excellent. Okay. So I think what we should do is that maybe in the interest of time, I think, Jürgen, you had a case to discuss and show to us. It's your case that's up. Should we do Jürgen's case first and then move on to your case? Okay, perfect. Jürgen, are you able to share your screen and discuss the case? And whilst that's happening, I think we will do at the end a little bit of discussion amongst ourselves as to how the multidisciplinary teams operate in different hospitals, especially case conferences.
Good morning. Can you see the slide in full screen?
Yes.
Okay. Actually, I'm a little bit surprised about the case presentation that occurred to me just 1 hour ago that I should prepare something, and that is why I chose a case which I already presented some years ago. It's not an immediate postoperative complication. It's an LAD stenosis following the arterial switch operations 3 months after the procedure, but still interesting to discuss whether to intervene and what to do. The patient had a TGA with intact ventricular septum and coronary anomaly with a LAD from a sinus 1 and the right coronary artery and the circumflex coronary artery from the sinus 2. Did a switch at 7 days, and the child was discharged 8 days after the operation, quite uneventful. 3 months later, child came to the outpatient clinic with slight symptoms, not really specific, but on echo and LV dysfunction and a pathologic ECG. You can see here the left ventricle, which was not pumping the way it was at discharge. And then we went in the cath lab to look up for the coronaries, and we saw this stenosis or almost occlusion of this LAD. So what can we do? We know that coronary stenosis occur late after the switch operation. Often they are clinically uneventful because there is time for collateralization. This child was more or less asymptomatic, and the question was, should we intervene or not, and what to do? There are several possibilities: LAD plasty, reimplantation, cabbage, or even try to dilate that in the cath lab. We looked up the literature, and there's a nice paper from the Necker group who had 25 patients with some sort of coronary problems they operated on after the switch operation, and they always had disappointing results with bypasses even in older patients. They proposed this coronary osteoplasty, but they also saw that the results are very bad when the LAD was involved. In fact, all patients with LAD involvement died following the procedure. So we can discuss now what we would do, or if you like, I could just finish the case, what we finally did. It's up to you, Apana. What do you think?
Let's go to what you did, so then we can maybe bring a little bit of discussion as to what people would do in other institutions.
Okay, our pediatric cardiologist, obviously she did not really know this paper quite well. She knew that we should address that. She already talked to the parents and said, we are going to operate child, and so I had no big choice. I had to go on and try to fix that. And we opted for an LAD plasty. This is the intraoperative view. You can see here the pulmonary trunk divided and the aortic root. This is the LAD, which was almost closed here at the site of the reimplantation, but with an adequate size of 1.5 millimeters at the lateral course. Now, this tissue is very fragile, and we thought that taking an autologous patch from the LPA would be the best to patch that. It's a little bit dark, that picture you see here, the pulmonary bifurcation, and this is the left pulmonary artery where we harvested this patch and put it on that LAD from distal to the ascending order. Of course, then the continuity of the pulmonary trunk was re-established, and this was the echo postoperative. Obviously, that worked. We saw the LAD here patent, and the child was discharged with no symptoms 8 days after that operation, and 1 year later there was a normal LV function and no ischemia. So this was a successful operation, but there are several other reports where that did not work.
Okay, no, Thank you so much, Jürgen. Any questions from the audience? Would this be something that would have been done in your institution? How would you have approached this case?
I can comment. I think it depends a lot of how your surgeon is confident with what he is planning to do. I mean, the problem of very young patients with coronary problems, either acutely after switch or other translocation or operation like this one, is how confident he is with re-repair and clearly bypass, because bypass, when you look at the literature in very young patients, is extremely rare. So this should be a discussion between surgeon and interventionist. I prefer clearly surgical approach in this kind of anomalies in very young patients. I'm not sure that intervention in coronary arteries of newborns is really the good approach. So I think if the surgeon is confident that he can repair or do a bypass, we recently had to do a bypass, but in a little bit older patients with a patient that came from another institution where they put a RVPA tube, and the RVPA tube was indeed stuck in the coronary artery. So he had to cut it and do a bypass. But I think it depends a lot of your surgeons. I'm sure that Jürgen agrees with that.
Yes, I agree. Well, I think I made the point that I was not very confident with that decision to operate on the chart because, as I said, it's not rare that patients after the switch operation lose one coronary. So they have a single coronary system and they're clinically asymptomatic, and that works. But in this case, we saw that LV function was not that good, and I think it was a good decision to opt for a two coronary system, because that's of course always better. I agree that an interventional approach is not good in those patients. We don't want to have stents in the coronaries in very young patients, and I'm quite convinced that most of the interventional cardiologists or adult cardiologists, they don't accept patients for stenting coronary osteostenosis at that age. So I think it was the right decision. Of course, we were lucky because it's not always easy, 3 months after the interventions, there are marked adhesions, and it's always risky to dissect the pulmonary trunk from the ascending aorta where both coronaries are reimplanted. So the risk for damaging the neo-aortic root and the other osteopatin is quite high. So there you really have to think of costs and benefit of this procedure. But as the child was symptomatic, we thought it should be fixed.
Thank you. I think that was very, very clear here, wasn't it? The child was symptomatic, something had to be done, and despite the challenges, you undertook the operation, and I think it worked out well for this child. Any other comments? Maurice, do you have any other comments? Or anyone from the audience have any comments?
I think Jürgen raised a lot of very interesting points, because there are several problems, for this particular surgery, because the neo-arterial root, the neo-aortic root, is really the weakness now we know for the arterial switch. So doing surgery on this particular part of especially after the Lecomte and all these different things, it's a risky procedure. But this child was unlucky, because I agree with Jürgen. We have seen, not in arterial switch, also in Kawasaki disease, where there is an obstruction of one of the coronary artery in very young patients that indeed develop the other coronary, and they can supply almost all the myocardium with the other one. But if here he was symptomatic, he has no time indeed to build this supply, and you have to do it. So really there, it's you need to trust the surgeon. And if we discuss what to do with the patient, I think the discussion is, and you raised that at the beginning of the talk, is you need to prepare the surgery with all the team and be prepared of the complication that you may face just after surgery. So, I mean, imaging is good after surgery, but if you already have an idea of what you can, I mean, probably plan as complication, that may helps a lot. So that's, I think the pre-operative meeting is really important between anesthetist, surgeon, cardiologist, and intensivist, so that you have a plan. So that's what we try to do in Geneva. Then we categorize the patients in green, yellow, and red. And you imagine what it means. It's based on the patient age and the RACS or the Aristoteles classification. And then the patient is again presented to the ICU the morning of surgery. And almost all our patients have a transesophageal echo after surgery done by the cardiologist in presence of the surgeon and the anesthetist. So I think the more you plan, the less trouble you have, and the better you choose indeed your imaging if you have a problem, or how you plan the decision to redo surgery, to go to the cath lab, or all these different things.
I think that's a great point, Maurice. It brought up a thought that I had, which is how these different institutions, all of us here, are approaching these multidisciplinary discussions. I can say from our experience at Boston Children's, we have a med surgical conference, which includes the whole heart center on Tuesdays and Thursdays, so twice a week. But if patients come into clinic on one of those off days and this decision tree has to occur not on one of the days that we're talking about patients, I'm curious how groups approach that when it's not on one of the days that you're having it sounds like you do a cardiac, the ICU has a presentation every day, potentially, Maurice, I'm not sure. But it's just with the conferences that we have this twice a week. And so if a patient shows up on a Friday, they may not be able to have a whole discussion across the heart center. So I'm just curious how people kind of tackle that when patients show up on the weekend or when the whole group isn't able to weigh in. How do you approach that?
So what we do is the same, but with the short team or the small team, which means the intensivist staff, the anesthetist staff, the surgeon staff, who is on staff, and the cardiologist. And at least we have a small meeting to discuss that if it's an emergency. And then it goes to OR and go back the same way that I explained before. If it's a sort of planned, we discuss the day before, and then in the morning again we have at the day of the surgery, the patient is again discussed between cardiologist and intensivist in the intensive care unit, just to explain the patient again, because sometimes you have discussed it at the med-surg a couple of weeks before. So we repeat that, and we discuss what could be what will be the surgery and what can be the complication. And then the surgeon comes back with the patient and the anesthetist after surgery. And if there has been a change or something in the OR that was not expected, then it's rediscussed when the patient goes to the ICU. I see that Angelo is in the room, so I think he can confirm that this is the way we approach that. And with that, I have to say that probably we're lucky, but we have few complications. Julie is frustrated because she has very few post-op cats, and I don't know if it will continue like that, but it works quite well. It does not mean that we always agree, but we usually find a compromise.
Thank you very much. Thank you for this. Should we move on to another case for discussion? And Kaylin's going to present a case from Boston Children's, and we'd love to have a very interactive discussion.
So this is also very much in real time. I put these slides together this morning. This is happening currently in our CICU at the moment. So we had a full-term neonate who had a prenatal diagnosis of hypoplastic left heart syndrome, mitral stenosis, aortic stenosis, with a dysplastic unicuspid aortic valve, who was born with moderate to severe aortic and mitral valve regurgitation. severe LV dysfunction and moderate RV dysfunction at birth, and initially had concerns for a circular shunt, but was born without high drops. So on day of life 1, underwent a stage 1 palliation with an RV to PA conduit, tricuspid valve repair, a partial oversewing of the aortic valve, and remodeling of the aortic root with plication of the non-coronary sinus. Came off bypass with moderate to severe biventricular dysfunction and moderate TR. See if I can play. Oh, I don't know if I can play the echo. Just going to try to show the echo, but oh, it's not playing. Oh, there it is. Thank you. So this was the epicardial echo that was done post-bypass, showing moderate to severe RV dysfunction and moderate TR. Next case. And then came back with his chest open after that case. And on 5 days later, for chest closure, had another epicardial echo that showed mild to moderate RV dysfunction and mild to moderate TR. Let's see if I can get that to play. If I magically, yeah, there we go. Mild to moderate RV dysfunction and mild to moderate TR. And this, again, was a epicardial echo done at the time of chest closure, 5 days post-op. So this was the patient's BUN and creatinine after the case. Basically, the 20th was day of life, 1, 0 into 1. And then, as we said, the surgery happened on the 20th, and then the 25th was chest closure. You can see that there was initially an improvement in the creatinine, and then really starting on around the 30th of April, you can see that it starts to climb and continues to climb. And then since chest closure, had remained intubated with progressive end organ dysfunction, including AKI, hepatic congestion, a hyperbilirubinemia, developed medical neck, and so was NPO on PN, and then had worsening respiratory failure. Supported currently on epi, milrinone, was sedated and paralyzed and nearing maximal vent support. On antibacterial, antiviral therapy, had an elevated white count, but no obvious source of infection, and on stress dose steroids. This is the lactate, just to also include where this has been. On surgery, peaked at around 10, and then had come down and been kind of within the normal range. So this is on the 2nd of May, showing some mild RV dysfunction and mild to moderate TR. Play that one. And then this is yesterday. Moderate global RV dysfunction and moderate to severe TR with mild neo-aortic regurgitation. So that's where this patient is right now. And that's where we're at. And I'm certainly, I can tell you what's happening, but I would love to hear what people think, what people's thoughts are.
Yeah, do anyone in the audience have any comments? And then we'll go to Morris and Jürgen to give their comments. Anyone? Okay.
What's your pulse pressure? Indicated the aortic insufficiency is too significant for the baby?
No, I think that the diastolic blood pressures for the neonate are in the high 30s, so it's not the aortic regurgitation.
And what was the degree of the tricuspid regurgitation before surgery?
It was, preoperatively it was moderate.
Moderate.
Yeah.
Isn't it a relative contraindication for Norwood, or?
Might be. Patient went forward on day of life 1. Yeah.
So if there is moderate, AV-valve regurgitation pre-op, how many here in the audience, would consider that as a significant contraindication? And you'd advocate for that? Hands up.
It's a risk factor, but not.
My hands is up, but
Okay.
I think
okay.
the comment is.
Okay, Morris, go ahead. Yeah.
Yeah, I couldn't see the picture, so that was a little bit difficult. But clearly for us here in single ventricles, the AV valve is something that really is a major trouble. So it depends a little bit how you can manage that. So we all try to do things. I've seen the case of the fontan of Jürgen yesterday. I mean, the discussion of what happens. I think when the failing fontan, when you have a bad valve, it's clearly a fontan that goes to the failing fontan. So it's not a contraindication, but probably a very serious discussion that you should have a beginning. I was interested also by something, because you said presenting the case that you do epicardial echo, and do you feel more comfortable in this population with epicardial echo than transesophageal? It's I know that there are discussions that, especially for arterial switches, that some surgeons prefer epicardial echo. You think you have all the answers with that, or is it better than transesophageal?
I would say that most of our surgeons do an epicardial echo at the end of the case as opposed to transesophageal. There's 10 of the surgeons, again, at Children's, and so it may vary, but most of the time it's an epicardial echo. I don't know, Ravi, if you feel differently, but I think mostly it's epicardial echo at the end of the case.
I think in Great Ormond Street as well, it's epicardial, but, and I think, the weight of the baby and, the ability to get through an appropriate size TOE probe sometimes makes a difference. Julie, you want to comment? Epicardial versus TOE, yeah.
Yeah, so in Geneva, we tend to do TOE for most of our cases. It's very uncommon that we can't fit a TOE probe. But I was just wondering for epicardial, so the surgeon is doing the epicardial?
Yeah, almost always it's the surgeon at Children's, yeah.
And who's managing the machine and who's interpreting the pictures?
The pediatric cardiologist will manage the machine and ask kind of direct the surgeon for different views.
20 degrees,
Yep.
round clockwise. Yeah.
Yeah.
That's pretty challenging. Yeah? I've done that in Australia, and it's not great for us, but you have to follow. And they like a lot of gain and a lot of color on the whole screen. So it's pretty different echo, but yeah, I guess. It's a question, and it's probably a habit also of surgeons, because a few years ago, very small children, we didn't have a good tiny probes, and I guess the new generation of surgeons probably would like some TOE with the new probes. So probably it's evolving. Yeah.
Thank you. Jürgen, your thoughts on the case
Yeah.
and this assessment at the end?
Comment to the echo, I think it's mandatory to have an echo postoperatively in the OR, just to be sure that everything is fixed, or to at least discuss the residual lesions and what you're going to do about it. We routinely do TEE, and that fits in almost all cases. In very small children or patients with esophageal atresia, of course, we don't do that. We do epicardia, and then the surgeon does it. And often our colleagues are impressed about the nice pictures we get from the epicardial echo, because it's really, really high quality pictures. What we do also is in TAPVC repair or repair of pulmonary venous stenosis, we do it epicardial in addition, at least, because often we see compression of the pulmonary veins by the TE. And in fact, there's no residual lesion. It's just the effect of the TE probe that makes acceleration of pulmonary venous return. And just to figure that out, it's good to have an epicardial echo to be sure that there's no problem with that. And to the case, I think, of course, moderate tricuspid regurgitation is some sort of contraindication to the Norwood operation, but depends on the alternatives we have. That the main problem is often tricuspid regurgitation when it's functional is not that present in the early 1-2 days after birth, because there is limited pulmonary blood flow due to high pulmonary vascular resistance. And when there is more pulmonary blood flow, tricuspid regurgitation will get worse. So sometimes we leave the OR with a quite good valve, and then some days later, when pressure drops in the PAs, there is volume loading of the single ventricle, and that AV valve starts to leak. That's the one thing. And the other thing is, I think it's important to know whether this tricuspid regurgitation is functional or whether there is a real anatomic substrate to it. Some patients with HLHS have diaplastic tricuspid valves, and then it may be possible during the novel procedure to address that. When it's clearly functional, it's difficult, and then we have always a problem, and that will turn out in a bad Fontan patient, of course, like Maurice said.
I think you raised a very important point for practical things. I agree with you that transesophageal echo after pulmonary vein repair is a very risky procedure, and the cardiologist should know that and never tilt the probe, because sometimes you want to see absolutely the vein and you start to tilt the probe, and when you tilt the probe, you compress the veins, and either you say to the surgeon that there is a narrowing, or the patient can indeed have pulmonary hypertension that is increased because of that, especially if you have removed bypass, and that's very risky. So that's one of the transesophageal that needs real experience to look at, but probably it's a good indication for epicardial.
Any other thoughts on the case? I can tell you what's happening. It's going to the operating room. Oh, yeah, go ahead.
One more thought.
Yeah.
I think that the subtype of hyperplastic.
Come here. I don't know whether
I think that the subtypes of hyperplastic that are MSAS actually do worse than mitral and tricuspid, mitral and aortic atresia. So that's another risk factor to consider and talk to the patient beforehand. Because I saw 1 second of the echo, the left ventricle is quite, it's moderately hyperplastic. It's not like severely hyperplastic. So that's also a risk factor.
Yeah, and it had severe dysfunction as well. I didn't comment on the left ventricle, but yeah, it had severe dysfunction as well. But this patient is in the operating room, not probably yet in the US, but soon will be, for repeat tricuspid valve work. So we'll see how that goes. But this is happening in real time.
Thank you so. Thank you so much for presenting the case, and I think giving us this sort of a platform for discussion. Any thoughts? I think single ventricle patients and any residual lesions or any of these preoperative factors like the MSAA, if there is any degree of valve regurgitation, a small little stenosis, in the PA branches, I think it's not tolerated really well in the postoperative period, and they are the higher risk, so to speak. So it'll be interesting to see. I hope all goes well for the case, and I think I will have to wait, and I think we'll have to wait and see how things pan out for your case. But yes, there are risk factors.
And I think this is important to have the Norwood operation not that late, because we all know cases from our ICU where then it is day 2, day 3, day 4, then is a weekend, and somehow within these days, our patients with only a right ventricle, then they crash, and then they get a full loaded ventricle, and then afterwards they get their regurgitation, and I think one should go to the earlier Norwood operation on day 2 or day 3.
Yeah, that's a good point. I think by and large, I think that's what's done in most institutions, isn't it? Yeah, like early as far as possible. But you're right, the weekend can sometimes make a difference. Yeah. Anyone else wants to make any comments?
And I think it's what makes the difference between the good Fontan or the poor Fontan. As Jürgen said yesterday, I think Fontan is playing to fail. But I think that most of what happened is that we discuss Fontan. Once they have the Fontan, I think the problem is before the Fontan. And what happens in the few years before you do the completion is probably what will predict what the Fontan, or how the Fontan will do. So clearly, if you start with problem at the first and the second stage, you can already probably plan that your Fontan will do poorly. So all the decisions taken early are probably the most important ones for the outcome of the Fontan long term. I think that's something that we're learning now and discussing if we still keep some pulsatile flow or not, if we delay or not the surgery, or if we do the surgery before or not. If you leave a leak for a few months in a patient, probably, I mean, these patients will have a ventricle and a pulmonary vascular bed that long-term will not be the best. So I think we need probably to rethink what we do in the first stages, and not only when the patient is 15 or 20 years to treat the fontan failure.
Yeah, I completely agree. And I think within the last 20 years, we changed a little bit our daily practice. If there are additional lesions like arch stenosis or stenosis at the DKS, anastomosis, or AV valve insufficiency, some 20 years ago, we tend to address that at the time of PCPC or TCPC, because we said, well, we are there anyway, so we're going to fix that with the next operation. But now we are very aggressive. If there is AV valve insufficiency, we will try to fix that in the interstage period, to have it done as early as possible, as we see that. And this it gives us better results with the next step. TCPC, for example, then is a very short procedure on beating heart. We don't have to address the AV valve. Patient is extubated in the OR and so on. And that's, I think, the better approach. Of course, there is more hospital admission and one surgery more, but it's important to address those lesions whenever they occur at the first place.
Thank you, Jürgen. There's a question from the online group, and I think this really plays into some of the risk factors that we're talking about with these higher risk patients, the MSAS population having tricuspid regurgitation, is in multidisciplinary discussions, how do you incorporate the parent's view? So open that up to the floor and to Maurice and Jürgen.
So to me, yeah, I think we are as objective as possible. I can tell you that we are already as objective as possible in prenatal diagnosis, because in Geneva, unless the family has special, I would say, religious background or something like that, most of the univentricular hearts are pregnancy that do not reach term. But this is probably linked to our countries. We're working with other countries where it's completely the opposite, in Poland. So I think you need to adapt your discussion with the family, hoping that you know very well the family. So I think it should be at least the staff cardiologist and surgeon that follows this family that should have this discussion and explain as objectively and transparently as possible what would be the surgical risk at this time, and what, if possible, is the potential outcome of the patient or the child in the next few years. So that's not easy, because you're just telling me something, because I'm indeed in Geneva because I have to see a family in 5 minutes exactly for this, and it's gone to the ethical committee. So sometimes it's not easy. But they should be part of the discussion.
Yeah, I completely agree. And I think we have enough experience now, and we know the outcome of the treatment we propose. Of course, it's true that it's different between institutions and countries. I used to work in France too, so I know the difference. And of course, if you're doing 15 overt operations in a year in a whole country, outcome will be different as compared, for example, to Poland. And when outcome is different, we have to explain that to the parents too. So I think it's important to know the results of the treatment, what we are doing, and not just perioperative mortality and morbidity, but also how is the patient doing at school? Is he able to drive a car? Will he get life insurance? As a job? And what's about pregnancy and later on? And all these things now we know, because we do Norwood since more than 20 years now. And that's why we have a very good impression of what to expect. And this is something we try to reflect as objective as possible to to the parents at every stage of the treatment, prenatally and throughout the whole treatment course. Yeah.
Thank you very much for that. But I do see sometimes, I think this is a very important question in today's day and age where you have families who do their own reading online and then they'll come back to us and say, you know, your multidisciplinary team discussion decided that there would be surgical abstention, just an example. And then they question us and ask us for, you know, for other opinions. And, you know, in fact, like say, can we have another second opinion from another institution? Now, I just wanted to get a feel for this. Do you find that happening in your institutions? I mean, in London, it is not uncommon. And like, for example, if this happens in Great Ormond Street Hospital, we'll ask Evelina Children's Hospital, JCC, Joint Cardiac Conference, to discuss the case and give their opinion to us. And vice versa, we do help each other out like this. So it would be really worth knowing whether that's a, you know, a signal of, you know, a feel that you all are getting in your institutions too.
Yes, in both ways. Either they ask a second opinion or they come for a second opinion. But I think it will be more and more common. We have no problems. Usually I refer to one center because it's a big center, and we have no problems to send all the documents and have the parents discuss with the other center. It's really not a problem. It's not so common for the current last 2 years at least, but it happens. Yes, internet is changing things.
Yeah, that's true. That's the same we observe in Munich, and but I think it's always important to get a feeling of the parents. If we know that there's a confidence, and then it's easy. Wherever we go, when we have the impression that there's not that confidence, it's become difficult, and then I propose them to get a second opinion.
Yes.
That's our opinion on that, but other centers may see that different, and it's clear to me that they want to have a second opinion. It's sometimes they have even a third, just to get somebody who has the same opinion like the parents. That happens too, but then they and this happens too in rare cases. They leave our hospital and go elsewhere, but it's the same vice versa. They also come to us, and then this is increasingly happening now. But I think it's okay, and the most important thing is always to have a common opinion of the team and to have it explained as transparently as possible to the parents.
But you know, as we push the limit now, and I mean, we can do a lot of things that we're not doing before. Sometimes this can happen inside the team, where the nurses or the ICU team or the cardiologist or the surgeon say yes, and the other ones say maybe we did too much. And then it's even more difficult to discuss with the parents. But this can even happen inside the team with now having access to technologies and surgeries that basically you always have the possibility to do something. The question is, should we do it? So sometimes the second opinion in another hospital, but sometimes you need a third party inside the hospital as well to try to find the consensus.
Mm.
Sort of, you know, supports the view of shared decision making when there are difficult situations, and I think, you know, having multidisciplinary input, having nursing input, having family liaison nursing teams, I think various other, you know, and sometimes in the, you know, odd case you might even have to use the ethical teams
Yes.
in your hospital to give you advice on these things. So yes, I think that's been a very good session and discussion so far. I don't know if anyone wants to make any more comments, but if not, I'd like to thank and Jürgen and Morris for joining us, and for everyone here for taking part in the discussion, and our online, audience.
Thank you.
Thank you, everybody.
Bye.